hosted by the Health Quality Council here in Saskatchewan. We bring together improvers from a variety of sectors who have an interest in improving their work. To learn about a variety of quality improvement related topics. All of our sessions are recorded and available on the HQC website following the event. So feel free to share these recordings with colleagues who are unable to join the live session here today. And feel free to check out some of the past sessions that you may have missed. While you're on our HQC website, we also invite you to sign up to our distribution list to ensure that you receive regular invites to all of our upcoming QI Power Hour sessions. Over the last couple of years, we've been really excited to see the continued growth of our QI Power Hour session throughout our home province of Saskatchewan, also within Canada, and even abroad. So we'd like to just take a moment to say thank you for spending an hour of your time with us and for your commitment to your ongoing learning to improve the systems that you are each part of. We're really looking forward to your engagement and participation on the webinar today. So we do encourage folks to participate in a number of ways today. So the first function that I just want to introduce you to is the chat function. So we do encourage you to share your reflections and your insights throughout the session by making use of the chat function. You can access this by clicking the message bubble towards the bottom of your screen. So you'll see, if you hover over the bottom portion of your screen, you'll see a toolbar that appears. So you can click on the message bubble there, and this will launch the chat panel on the right-hand side of your screen. So we encourage you to share your questions, comments, and ideas throughout the presentation. We will have some dedicated Q&A at the end of today's session, so we anticipate having about 15 minutes that you can interact with Dennis and Susan. We do encourage you to share your questions to all of the participants so that everyone can follow along in the conversation. The next tool that we're going to make use of today is the annotation function. So you can access this by clicking on the annotation icon on the left-hand side of your screen. So this will launch a second toolbar, and we'll be making use of the arrow icon. So just to give you guys an opportunity to test that, I'd like you to indicate where on the map you're joining us from. There we go. Welcome. Welcome, Charles. Welcome, Joanne. Welcome, Stacy. Excellent. Oh, wow. So it looks like everyone has found the annotation function, and it looks like we have a lot of representation from our home province in Saskatchewan here. So welcome, everyone, and thanks again. Finally, we also invite you to take part in the conversation of our session today by logging into your Twitter account. You can use the hashtag QI Power Hour and the handle HQCSask. I've also included Dennis and Susan's handles here as well if you'd like to tag them in your posts. So with that, let's dive into our session today. I'm delighted to welcome today two of our province's strongest healthcare change agents and quality improvement champions. Amongst the many roles that they've held over the past number of years, we're also very fortunate to currently have them both at the helm of our ship here at HQC. Dr. Shaw is currently the board chair for the Saskatchewan Health Quality Council, as well as the Chief Medical Officer of the Saskatchewan Health Authority. Dr. Shaw balances a rewarding career in critical care medicine and anesthesiology with clinical and system improvement work at the local, regional, and provincial level in Saskatchewan. Susan is looked to as a leader in patient-centered care, physician leadership, continuous improvement, and large-scale change. Dr. Kendel is a family physician who currently serves as our interim CEO at the Health Quality Council. Through his experience in a succession of leadership roles, he has developed an interest in improving population health through policies and practices that reduce inequity and other social factors that adversely impact people's health. Welcome to you both.
Glad to be here.
Good morning. Pass things over to you.
Well, good morning, everyone, and thank you for joining us. And we look forward to talking to you and talking with you over the next hour. And thanks, Chelsea, and to the rest of the team at HQC for all the support in putting not only this QI Power Hour together, but the entire series has been fantastic. Over the course of the next 40 minutes, Dennis and I are going to walk you through a brief introduction to Health Quality Council and some of the work we've done. We're going to discuss some of the limits that healthcare and medicine actually can have on an individual's overall health and wellness. We'll talk a little bit about the social determinants of health and what we mean when we talk about upstream thinking. And we can talk a little bit about what actually makes Canadians sick and unwell. Next, we'll review at a very high level a bit of the global shift that's happening all around the world to recognize that to actually improve health, we need to focus not just on healthcare, but also on learning how to improve the social determinants of health. And next, we'll talk about how does our organization, Health Quality Council in Saskatchewan, see ourselves as making contributions to this next new exciting space for us. So first of all, before we launch into today's session, we do recognize that we may have many new participants joining us on the Power Hour today, and we wanted to take a bit of an opportunity to tell you a bit more about our organization and what we do and what we have done. Our Health Quality Council is really the first of its kind in Canada. We were established in 2002 with a legislative mandate to accelerate improvement in the quality of healthcare in Saskatchewan. Since then, HQC has been working to make healthcare better and safer for everyone in Saskatchewan. Over our last 16 years, HQC has played a key role in helping to establish dedicated quality improvement departments throughout the healthcare sector. We've done a lot of work to train clinicians, administrators, researchers, and quality improvement specialists, patients, and families in quality improvement science. We've led teams of engaged stakeholders and collaboratives that have worked to improve specific areas and aspects of healthcare. And we've played a big role in supporting the measurement of health system performance and reporting. And I'm particularly proud of the work we've done to help establish the infrastructure that allows patients and families to partner in their care, including through co-design. Today, we're excited to spend some time with you talking about our next chapter of the work. And we're excited to see some of our current partners and some of our new partners joining us on today's session. Welcome, and we look forward to sharing this time with you today. As Chelsea shared with you, I am a critical care doctor. My clinical work is to look after patients and their families who have experienced injury or illness that puts their life at risk. Most, if not all, of my patients require some form of life support. About 5 years into my practice, I had the opportunity to look after a 27-year-old man. He had suffered a life-threatening brain bleed following gang-related violence and assault. Once I'd made sure, and my team had made sure his immediate care plan was safe and appropriate, I sat down to read through his old patient records at the hospital. And I discovered that this was not his first time needing intensive care unit. It was actually his third time being admitted into my unit. And this is the third time we had rescued him. What I realized at this point was that our healthcare system was set up really well to save this man's life, but we weren't actually helping him achieve health and safety. I then looked around at the other 10 of the 12 patients I was looking after at that same time that week. And 10 out of 12 were needing my team's care for what could really be seen as preventable disease and illness. They were admitted to intensive care with complications of smoking, alcohol use disorder, intravenous drug use, complications related to poverty, and a lot of intergenerational trauma. This really changed the way I saw my work. My care as a critical care doctor was very important, but by itself, completely insufficient. We needed the whole system to think differently about how we help and support health and the creation of wellness. Many factors other than healthcare have an influence on health. In addition to our individual genetics and some of our lifestyle choices, where we are born, where we grow, where we live, work, and age also have important influence on our health. The social determinants of health are the broad range of personal, social, economic, and environmental conditions and factors that determine your actual individual and population health. The main determinants of health are very familiar to us. They're things like access to stable housing, stable food, your early childhood education, whether you're able to read and at what level, what your early experiences are in your childhood, and what type of behaviors you're able to support. And a lot of that's based on who you are, where you're born, and your ability to find stable work. Those are a lot of things that may or may not be within your control, and it's important that we understand the impact that they have on your health and your community's health. This is a different way of looking at the social determinants of health, and I really like this one because it shows that as an individual, there's still some things that have a big difference, but you don't get to choose how old you are, what gender you were born, or what genetics you were given. You don't get to choose from parents. There are some individual behaviors that also have influence, but many of those come and are influenced by other factors, including what services and infrastructure you have available to you, what the conditions are in your environment, and what other kind of societal factors are in play. Within the exception of the healthcare services, all of these factors live outside of the healthcare system. To date, the Health Quality Council has really focused almost exclusively on optimizing the quality of healthcare services. This has been incredibly important work, and I'm proud of what we've done. We've been able to work collaboratively with many organizations that deliver or support healthcare services, and that really has been the right work and will continue to be a part of how we fulfill our mandate to improve the health and healthcare for the population that we serve. But as I realized in the ICU that day many years ago, by itself, working on healthcare will be insufficient if we really truly want to support healthy people and healthy communities. Many of you on this Power Hour are very familiar through your experience and expertise in quality improvement with the concepts and methods of root cause analysis. Thinking upstream means thinking about the root causes of the actual outcomes we are seeing downstream in the process. Putting this into the context of healthcare, upstream thinking means thinking about the social, economic, and environmental factors that influence an individual and a community's overall health. Some of you will already be familiar with this image for healthcare. Often we in healthcare are rescuing and saving people that are struggling in the river. This is important work. People need the services of primary health care, people need emergency rooms, and we need medical specialists. But thinking upstream means we also get to cast our gaze up more broadly and ask, why are these people falling into the river anyway? We need upstreamists thinking about care redesign and how to bridge the work of healthcare providers with partners in the community to address what's actually happening upstream. They help address the non-medical root causes of major healthcare problems, like a lack of housing, food insecurity, or social isolation. So we're going to test our online tools a little bit here, and we're going to do a poll. We just want to remind you that to participate in the poll, we're going to use the annotation function. You'll find this function on the far left-hand side of your screen toward the middle. First, select the annotation icon. This is going to select and launch a set of annotation tools that you'll find on the left. From here, select the arrow pointer to cast your vote, just as you did on the big map. So, what percentage does healthcare contribute to our overall health? Let us know what you think. Use the tool to find out where you're at. Well, I think we're talking to a pretty informed group of our participants today because I think when you look at where our participants put yourselves, you put yourselves between about 20 and 30%, and that's absolutely dead on. This is an infographic done by the Canadian Medical Association, and it classifies the social determinants of health in terms of their overall contribution to Canadians' level of sickness or health. It actually took me another 5 years about my aha moment looking after that 27-year-old man in the intensive care unit for me to actually start to really understand that as important as my work is and our work is in healthcare, that by itself it will be insufficient. We figured out through the work of many others that really the healthcare system at its best, no matter how much we improve it, can only influence about 25% of an individual's health. And at first, I have to admit, I found this to be quite deflating. I spent many years learning how to be a physician and learning how to take care of one patient at a time and how to work on a team. And I'd even spent quite a lot of time learning how to improve health care. But with a bit more reflection, I actually found that this discovery about the other factors that improve health to be quite empowering. Just as in our quality improvement work, if we can understand the systems and processes that have impacts on health and healthcare, we are actually able to have much, much greater impact. And this isn't just a shift in my thinking or in the shift of many within Health Quality Council. We're seeing this in organizations all around the world. These are just three large and significant organizations that are starting to lead in the space of understanding intersectoral work and what else creates health and healthcare. The Health Foundation and the King's Fund in the UK and the global organization, the Institute for Healthcare Improvement, have all begun signaling that population health will be a key area of focus in their work into the future. And we already think about that in Saskatchewan when we think about our quadruple aims.
So from the inception of the Health Quality Council until 2017, I was privileged to serve on the board of directors, and I well recall at that time that when the IHI adopted the triple aim, that means better health, better care, better value, the Health Quality Council adopted that, but we added a fourth aim, that being better teams, because we realized that effective teamwork was critical to achieving better health, better care, and better value. And when you look at this graphic depiction of our vision, it's noteworthy that we put better health right in the center, and the better health dot is bigger than the other dots. But if we're honest with ourselves, the fact is that we were so preoccupied with making health care better, that rescuing people from the river that Susan described, that we really didn't put much attention on how we could influence better health. So now our board has made a courageous decision to actually redirect some of our future activity to influencing the determinants of health. And I'm personally excited about this. And I now find myself in the role as interim CEO, and I and the really talented team here now have both the challenge and the opportunity to actually make this happen. And I'll be humble and acknowledge that we're just in the early stages of this journey, so I'll give you some sense of how we're going about it. If you look at the slide down at the bottom, you'll say putting patients first. And since the patient first review was done in 2009, that's been our mantra. Many of the agencies in our province put patients first, and we're proud of it. And we're going to continue to do that in the work that we do in the healthcare sector. But if we're going to influence the social determinants of health, we need to actually engage people before they become patients. So we're going to have language that addresses our relationship with people before they ever become patients. When we were early in the days of patient and family-centered care, our concept of engaging patients was just to listen to their stories and try and apply it. We've moved on to actually directly involve patients as partners in co-design. And this slide depicts the fact that as we move forward in the social determinants area, we're going to have to work together in true partnerships. I love the fact that people have their arms around each other. They just aren't walking close to each other. They're actually embracing each other. And we're going to have to form really solid working relationships with many partner agencies outside the healthcare sector in order to do this work. We had an initial meeting with some community-based organizations to ensure that we would get an early understanding of how they're working. And it was an inspiring meeting on the one hand, and yet humbling in the sense that I realized often we were speaking the language of healthcare and we need to learn to speak their language. And then I came away from that meeting asking, what would be the first step we might do to actually begin to do pragmatic work? So if we go to the next slide, I'll just say that we listened to the stories of these organizations, and in their own field of impacting the environment in which people live, they were doing amazing things in relation to education, housing, food security, but there was little in the way of coordination of their work. And one of the things we've identified at this stage is that we could probably use our fairly significant analytical capability to take data that these agencies are collecting and collate it and integrate it in order to improve their collective impact. So in a sense, we would be empowering them to make a bigger difference. And as we work in this space, I think we'll find more ways for us to work effectively with partners. But We describe this as a journey. Our focus areas come from an exercise we call a roadmap. And I think that's a very apt term because we're on a road traveling sequentially from one place to another. In each community, we'll meet new people and we'll find a way to work with them. I'm excited.
Well, that brings us to the close of our formal presentation. We'd really like to use the remainder of our time to engage with our audience. So we're delighted to see the number of participants who have joined us on the call today. So what questions do you have for our board chair and our CEO? I see a comment from Joanne already appreciating Dr. Kendel's honesty and kind of that honest reflection that you know, it's humbling, as you said, Dr. Kendel, that to think that, you know, in a sphere that we've spent, some of us, the majority of our lives in, to look up and kind of recognize that we are a very large system, but we're a system operating within a bigger system. So it's both exciting and humbling to make that recognition for sure. So I'll welcome people to pose questions through the chat. We're also excited to bring you along in the journey. So we've created a landing page where you can sign up to receive further notifications about our new strategic direction as it develops. As Dennis mentioned, we have an idea of where we want to go, and the plan is kind of unfolding as we walk along that path. But we'd love to bring you along that journey and that conversation. And we'd also welcome your ideas and your questions as we go through. So what ideas do you have? What do you think that we need to continue to think about as we develop this plan? So you'll notice that there's a link coming through the chat right now. So you can click on that link to sign up to be part of this process, to be kept up to date. And you can also feel free to pose questions as they pop into your brain, perhaps after the session, directly to our CEO. So he welcomes that, and you'll find a link to ask him a question on that landing page as well.
See, there's a question.
Yeah, I see some questions coming through here.
Can I address one?
Please do. Please address all of them.
So I see a question asking how we anticipate going about identifying the community groups. Again, recognizing that we've just begun this work. Our very first event was convened in Saskatoon, because that's where we're based, but we recognize we're going to need to travel around the province to meet with a broader spectrum of groups. At the first meeting, we met at Station 20 in Saskatoon, and the groups present ranged from Habitat Humanity, which is an international organization with a footprint in Saskatoon, to very local organizations like AIDS Saskatoon and others. And I guess one good thing is we appreciated that many of these people knew each other, that they have knowledge of each other, they respect each other's work, but they are quite siloed in the terms of their dependency upon funding, sometimes quite uncertain funding from multiple sources. So as we expand our capacity to meet with more groups, we want to go to more communities and also extend an open invitation to any agency that thinks they would be interested in working with us on this journey to get in touch with us.
I think the other thing that, again, we're early on this, but we definitely, you know, at the board level have seen that this is the right place for us to go. What excites me is that we're learning, we're going to be able to apply what we already know and our skills, our knowledge, and our experience in quality improvement, and really take that into outside of healthcare, into that intersectoral work. So it's going to be applying our knowledge to a new subject matter in a way, but it's also going to be a learning journey for us as well. The other thing that I think we really want to see is that we do have a health system that's going through transformation, and really that is based on a foundation of primary care. So that's going to be very much about understanding needs of communities, and we are small. We're small and mighty in Health Quality Council, and we're going to have to be strategic in how we determine where we apply our abilities, and I think it's going to be very much in aligned with how a bigger system is taking us. So I can see us working very much in the space of learning about inequity, learning about disparity, learning about opportunity to partner and bring together organizations that perhaps would like to but don't know how to apply quality improvement methods. And it's going to be a lot of we don't know yet, but we're going to learn together.
I see a question about engaging municipal groups, housing, community design, infrastructure, and certainly that is something we need to do. We also need to begin to work intersectorally with the other ministries other than the health ministry, particularly justice, education, social services, and probably others. There's some pretty powerful stories. Our own deputy minister at a meeting I was at earlier this week told about his visit to St. Teresa School in Regina. And the fact that just embedding a social worker in the school and helping the kids support their continuing education, and they've now achieved, I believe, a 90+ graduation rate, which was very much lower before. Getting young people to complete their education and hopefully even pursue advanced education has huge payoff in terms of minimizing the risk that they will find themselves in trouble with the law or get into other difficulties in life that will impair their health. And so I guess one of the things we're conscious of is that when you look at the way the public tax dollar is spent, healthcare now in most provinces consumes 40+% of the total budget. And so in some ways we're starving funding to other sectors of our society that can make those investments upstream. And so I think we have a role even in influencing policy to make sure that we get proper balance and investment in the early determinants of health.
I see a question here from Corey Newdorf. How do you see HQC working with other groups working in this area already to do more in a coordinated way? So examples of the Public Health Observatory in the Saskatchewan Health Authority, researchers at the UBS.
Oh, that's exciting. Good morning, Corey. I'm glad you're on the call. We've been thinking about you because I certainly this isn't about taking over or getting into areas to compete with organizations such as the ones you've identified. It's about building relationships, learning from organizations that are already having great success, using data for improvement and data for policy and data for change to be able to make a collective impact. So I see, again, we're early. This is part of our early signals of where we're heading, and we want you to help us decide where we go next. So I think it's great that you're on the call, and it's about learning how to work well with organizations such as the ones you've already identified.
I just want to put in a plug for some of the work, for instance, done earlier to map by postal code, social status indicators and health status across Saskatoon, for instance, and we need to see that done province-wide, is a very powerful tool to understand where we need to direct resources to change the life reality for people.
Thank you. I see a comment here from Cora from the Population and Public Health in the Saskatoon area. Just, again, recognizing that we're new to this space and that much work has already been underway and continues to be underway. So calling out kind of the importance and asking for the plans to integrate with that work.
Absolutely. And I think that's certainly, there are other organizations that have strengths in integrating and collaborating, but that's definitely the way HQC has always done and should continue to do our work, is through integration and alignment. So we do not want to get into competition. We want to be, how do we support and how do we learn and apply what we know and our resources to have greater impact with the work already underway, while also maybe identifying new spaces that have not yet had the opportunity for investment of resources or time and expertise. So I think very, very good points, and it's great to have you on the line.
So another comment from Caitlin Herbert. The new budget announcement will certainly bring light to this upstream focus. What is happening at the provincial government level regarding this resource allocation clarity?
I don't know if we can answer that question. I do agree there are some signals in the media that there's going to be more investment, hopefully, into an upstream focus, particularly, I think, in mental health and addiction. I see that as an opportunity. I certainly wouldn't speak for government on how they're seeing their work, but we see ours as being able to really capitalize and support the work that needs to be done.
So, well, we know the budget is coming down on March 20th, so I guess we just all have our hold our breath till then. I do want to say again, though, that our own Deputy Minister in Health has signaled that the working relationship between the various ministries in the human services sector is growing stronger, and a recognition that we have in executive government lived in silos for too long, and we need to actually bridge that. It's interesting, Canada, Quebec is innovative in the sense that for all its history, social services and health has been one ministry. It makes for a very large ministry, but even in that combination of those two ministries, you avoid the artificial divide between health care expenditures and social sector expenditures.
Brilliant. Another question. You referenced data sharing, Dr. Kendel. How do you see organizations being open to share with parallel organizations to make this collaborative coordination to improve the health outcomes?
Sure. Okay, so I would just want to say, first of all, we have access to, at the moment, a lot of administrative data in the healthcare sector, and we use that data to drive research that helps improve healthcare. We have been in contact with an agency in Alberta that has shown its capacity to become essentially what we would call a backbone organization for organizations that want to give data to the agency, and then the power comes often in linking databases where you can find the connection points and synergy in terms of what you learn from one database to another. So I guess I would just say to agencies that think they might profit or benefit from having some working relationship with us, again, get in touch with us, and we have some really talented people who use data very effectively, and I think we'll just need to explore what we can do together. I think the possibilities are great. I just have to, again, repeat that we're taking baby steps at the moment. And we will grow more confident as we actually learn how to walk on this journey.
A question from internal here. I'm curious as to what you've heard about or seen at play in other either healthcare sectors or industries or organizations from around the world that have kind of led out in this area and some early promising things that they've...
Well, one of the things that really impressed me is Kaiser Permanente in the U.S., which is infinitely clearly a healthcare organization, is now making an investment in housing and service areas. And when you think about it, for instance, when you think about a homeless person, for instance, who encounters trauma such as Dr. Shaw described, and you rescue them and you bring them into an ICU and you patch them up and bring them from the brink of death, sending them back to the street is just not humane. So I do think that if we're beginning to see healthcare organizations in a highly competitive commercial environment in the United States making investment in housing, I think the lights that are coming on is that this is good business to actually invest in housing security, food security, because you'll either pay some money now or you'll pay a whole lot down the line. And so that's what I see to be the innovative thing happening internationally. There's awareness that this is not just a charitable thing to do. This is a smart thing to do, and that's so encouraging.
And we've seen work like that already done in our province, and again, HBC's played a role in some of the data that supported the strategies of helping identify people living at risk and putting supports around them, including stable housing, and that's some impressive work done and led by others, and I'm excited that we've had a role in that, and I think we can build and learn more on that. The other one that really interests me is when you look at Scotland and you see, they've set a strategy of it's the best place in the world to raise a child. And both the healthcare sector and, you look at what Healthcare Scotland has done by partnering with education, social services, and justice. And a lot of their initiatives have been about how do you get kids reading and what impact that has on health, what impact that has on the family, what impact that has on the parents, and how you can actually do, I'm not going to say it's easy, but very relatively simple intervention and can have ripple effects throughout the entire system and actually life of that child who's our future adult, right? So our future citizen, they are our citizens. So I get really excited when I look at what Scotland's been able to do. And I'm also excited and inspired by the work that, like we said, the Health Foundation, IHI in particular, where they're showing that you can translate the knowledge of quality improvement and see great effect where you partner that with other organizations that know way more about these areas that we haven't traditionally looked at.
Absolutely. We kind of take our roots in quality improvement in healthcare from, in fact, another industry in manufacturing.
Exactly.
So now we'll be kind of paying it forward outside of healthcare again to maybe partner with some of those human organizations. I know that in our early conversations, socializing kind of this new idea of where we would like to spend some focus on, some of our initial reactions from our current partners have been like, what, you're abandoning healthcare? You're leaving us? What would your responses to some of those types of questions or comments be?
Absolutely not. So I think that we have a legislative mandate that we are to do work in the improvement of healthcare, and we do have important work that we need to continue to do. I think what we will see, though, and it's work that I'm very proud of, that as we've been successful in building capacity for a healthcare system that does have a lot of improvement science specialists and a lot of people who understand what used to be kind of held in our own little silo. We've been successful. We've built that capacity into the broader healthcare system. We'll continue to support that. We're going to continue to look forward to see what are those missing elements that are being discovered elsewhere, or what are we discovering locally that needs to be translated into our healthcare system. But what this allows us to do is to acknowledge the success that we've had and really evolve to move, not to abandon, but to keep supporting that while looking at what the next new opportunity is. So it's not an either or, it's one of those classic both ends, and they're so complementary. And that's what I really like about upstream thinking. It's very familiar to people who do A3 thinking or do quality improvement work. It's like, what problem are we trying to solve? And not jump to solution, but actually understand the true root causes. And a lot of the root causes of poor healthcare or poor outcomes in healthcare or things outside of the healthcare system. And so that, I think, is why this is an appropriate evolution, but it's not leaving where we've come from. It's recognizing what we need to do next.
Well, I'll just comment as the interim CEO, emphasis on interim, is that the job of the CEO and the whole team that works with me is to implement a policy decision made by our board. And so I do think it's important, we call this a new focus area. So as Dr. Shaw said, we're not walking away from our role in improving healthcare quality, but I'm also sensitive to the fact that if we were to apply a very minuscule part of our resources to this, it could be rightly seen as tokenism. So for the moment, and again, we haven't yet realized the full impact of this in our operations, I would say in the next fiscal year, we'd want to see about 25% of our resources go towards this upstream work and probably 75% in the work which is a pretty responsible balance. And it's quite conceivable, as we see fruit being borne by that there would be support for even increasing that ratio. But at the moment, that's the target I've set operationally, because I want to be sure that we actually have real resources. One of the things we had to make clear to community agencies when we met with them is we aren't coming with a blank check to actually we're not a funding agency. We're not a channel through which they can get more funds. What we can bring is our expertise to the work, and I think that'll prove quite valuable.
Thank you. Thanks for making that clarification. One of the questions that came through privately was just kind of a blue sky thinking, what does long-term success look like for HCC in this area? If we were successful in 5 years, what would that look like?
I think we'd see a great question. What a great question. But what I think that we will see, we've talked about this at the board, and we're starting to understand what it would take within the organization to get there. But I really think in 5 years, we're seeing relationships built with organizations and communities that didn't exist before, with skills built into those organizations. Like again, we could just do things to people, but that's not effective. We want to do and build and support skills into people and organizations. So I think in 5 years we'll have relationships we didn't have before. We'll have a flow of information that actually supports analytics that drive improvement and policy, and we'll see capacity within communities to be able to self-identify and have some skills and resources available, internal resources to be able to do their own improvement work. The other thing is supporting that intersectoral work, and we see that we are seeing that within our ministries. We're seeing that within the health authority, and we're definitely seeing that as an opportunity.
So I think in the very long term, of course, you would be able to do measures of population health status, and we have just horribly unacceptable equity gaps in population health in this province. So as a group, for instance, First Nations Métis people have significantly, they have shorter lifespans, and they are subject to greater ill health. And so, quite frankly, there are already some pretty intensive expectations that we should try and play a role in narrowing those measurable gaps. Intermediate measurements, though, I would think would be things like, keeping young people in school, reducing the incidence of incarceration of young offenders. Quite frankly, I mean, there's been some exciting work done in that already by CSKA around, between the education and justice systems.
CSKA.
Boy, you're going to test my.
It's Knowledge
Association, right? Yeah, I was having a senior moment there. I'm an old guy, but it was the first effort in this province, and started by Dale McPhee, who was serving as the chief of police in Prince Albert, and became utterly he's Métis. He became utterly depressed at the incidence of young people finding themselves incarcerated. So began to work intersectorally with the education system and social services. And that's yielded some real tangible results. And so I think we know that you can measure results incrementally as you go along. You don't necessarily have to wait for a 10-year measure of gap narrowing.
Great question from Diane coming through the chat. I'm very interested in the challenge of engaging with community members who have lived experience of inequities. I'm calling this grounded expertise. How can this happen? How can the voice of grounded expertise be centered? And how can we engage meaningfully? Great question.
It's a very good question. And I think that's something that we've started to talk about. Certainly this builds, so when you look at the work that we've been able to do in support for patient family-centered care, I see the natural shift is going from patient and family-centered care to community-centered care. And it's about understanding, do we have the right diversity, or are we actually achieving diversity in who our patient, family, and community advisors are? I would put forward, and I don't think it's with much challenge, that when we don't have a significant or a sufficient diversity there for people, and I love your phrase, Diane, of grounded expertise. I think that's a very powerful way of describing something that I do think we're missing. So I'm trying to see, we can just head back to the rest of the question. How could it be centered, and how do we engage meaningfully? I think it has to be actually, I think meaningfully is important. It's built on building respect, building trust, and building relationships. And that happens not quickly, that happens with time, and it happens with purpose. So I think that would be absolutely, and I know that Dennis and the team has already started building some of those relationships with new organizations, and it's a matter of purposely doing that. I think we can learn a lot actually from BC, Patient Safety Quality Council as well. I'm quite excited, and I see Chelsea's on the way. I saw Chelsea's name earlier, but I think there's a lot we can learn, both locally. I think there are groups who have done this very well, and I think that there's other organizations that are learning how to do this, and they can teach us.
So, Diane, I just want to respond as well. I think the good news is we've learned a lot, I think, from our early initiatives in terms of getting patient engagement based on lived experience. And like Susan, I love that term grounded expertise, because often, people didn't recognize that life experience builds expertise, valuable expertise, and listening to people who have had these lived experiences is a powerful way to know how to do things better. So in the patient advisory group, for instance, today, I mean, you'll see more and more healthcare agencies having patient advisors on their boards or on their various committees and activities. And I think as we build these working relationships with the broader group of agencies, the lived experience of people will be a really important thing. And even, I would just say, Diane, I don't know if you've had an opportunity, for instance, to tell your story to a larger audience, but we use patient stories as powerful ways as a representative experience. So if you want to reach out to us, we'd be glad to help you.
I think it's important to acknowledge, and this is not just work for HQC, but for more broadly, that there are barriers to being able to share your lived experience, particularly if you have, so I would say, the more disadvantaged your people's situations, the more inequities people face, the harder it is, because it's hard to take time off work, or hard to travel to an event, or we have barriers that we don't acknowledge. So I think it's going to be a lot more about going to where people are rather than having people come to where we are. So it's very much, and I think that's part of building that relationship. But I do worry about that, and I think that purposefully making sure that we are paying attention and very respectfully making it easier to have people who know the most, who are the experts, to be full participants. They're the experts. Yeah.
There has been some dialogue. The initial comment was inquiring as to whether we were thinking of kind of amalgamating a list of services or contact information kind of across sectors, so clients can be connected in real time with the services that they need. And then some dialogue that 211 from the United Way is a great service. And even the recognition or recommendation that Saskatchewan look into then kind of analyzing that data as to understand the draw on the different services. So some great ideas and suggestions and feedback coming through the chat as well. So we appreciate all of your questions, but also your recommendations and your general thinking as to your gut reaction to HQC moving into this direction.
There was a question that there was like a little flurry of questions there, and somebody I missed who wrote it, but somebody did ask specifically about how would the Truth and Reconciliation calls to actions fit into this. I do see this as part of our organization's response to TRC's call to actions. And when you look at the calls to actions that are specific to health, we are actually able, I think, through this work to go beyond the healthcare-specific ones, which is where traditionally an organization might look, but actually look at what are those other impacts and what are those other obligations that we have as institutions and as individuals to meaningfully respond to the calls to action. So that, again, that's in a way, it's not new, but it's a different way of working, and so the organization has already done some intentional work at building relationships with First Nations and Métis leaders and communities, and again, it's going to be how do you build respectful, meaningful relationships, establish trust, and meet people where they are, walk alongside with those leaders and those organizations, and work in partnership. So I do see this as being part of our organization's obligation to respond.
I just want to say that we deliberately kept the scope of this Power Hour wide on social determinants of health. We do actually have another focus area directed more specifically to First Nations and Métis health status gaps. I think the reason we let out with this first is that we're just incredibly conscious of the fact that the past abuses in terms of research with First Nations and Métis communities, which was addressed through the OCAP principles, we just want to take time to build trusting relationships with First Nations and Métis leaders and communities before we go out talking about what our plans are. So it's out of respect for the fact that relationship building comes first before even suggesting the journey pathway. In the broad sense, we have some sense of journey. In that particular space, I suggest we need to respectfully listen for quite some time before we even describe the roadmap.
Thank you. Well, I see that we're getting close to time, and I thank you all on the Power Hour today for engaging with our speakers. That's exactly what we were hoping for, was the type of dialogue that we've had today. I just have a couple of closing out notes that I'd like to make a plug for. So I'm going to ask our lovely Dr. Shaw to show we're upping our ante, we're upping our game on QI Power Hour with this highly coveted speaker gifts of I Love QI socks. So if you check out Twitter, you'll see that both of our speakers today are wearing the same socks. So if you would like to get your hands on a pair of these highly coveted items, we'd love to hear your idea as to a topic that you would like to share with our learning community. So you can check out the link that's being shared in the chat right now. And this is a link where you can put your name down and a topic that you'd like to explore with this community, and we'd love to chat through your ideas. So we'd welcome you to do that.
I just want to say, Chelsea, that when Susan and I both put on our QI Power socks this morning, I feel so much empowered to have both of us have them on. So if you really want to feel empowered, you need to get some of these socks.
They're a great conversation for
very, very effective.
And I just want to introduce next month's QI Power Hour session. So join us next month, which will be April already. April. Unbelievable. Where we'll be welcoming Jessica Hamilton and Laura Schwartz at the Health Quality Council here. They're both researchers for their topic, Getting on the Same Page, the difference between data for improvement, data for research, and data for accountability. Have you ever struggled to get your team on the same page when you're trying to develop a measurement plan? I know a few of us, probably even in this room, have had those conversations. Join us for this interactive webinar to learn more about the characteristics of each type of measurement, when it's appropriate to use each type, and examples of what each would look like. So that session is scheduled for Friday, April 26th. Just a reminder that you can register for that session immediately, and even better, sign up for our distribution list through our HQC website page. So that brings us to the close of our session. As we mentioned, if you are interested in keeping in the loop as to our strategic plan as it continues to develop, we'll encourage you to sign up for those updates. And we will wish you a happy Friday. Thanks once again for joining us.